Again, good morning, everybody. For today's talk, we have a slight change. I'll be presenting Dr. Castriotta to you, but he will start with the overlap syndrome talk. So to introduce Dr. Castriotta, he is a professor and medical director of clinical medicine at the University of Southern California Keck School of Medicine in Los Angeles, and a professor emeritus at the University of Texas Health Science Center at Houston McGovern Medical School. He served as a professor of medicine and director of the Division of Pulmonary Critical Care and Sleep Medicine at the University of Texas Health Science Center at Houston, and chief of pulmonary medicine and medical director of the Sleep Disorder Center and Pulmonary Physiology Laboratory at the Memorial Hermann Hospital in Texas Medical Center in Houston. He served as the president of the Southern Sleep Society, chair of the Connecticut Thoracic Society section on sleep medicine, and chair of the American College of Chest Physicians Sleep Network Steering Committee. He is a fellow of the American Academy of Sleep Medicine and American College of Chest Physicians, and has been a pioneer in the field of sleep medicine, establishing one of the early formal sleep medicine training programs in 1999 in Houston, Texas, and one of the early sleep disorder centers in 1981 in Hartford, Connecticut. Dr. Castriotta conducted a landmark study of sleep disorders after traumatic brain injury and has served on the U.S. Department of Defense expert panel for clinical recommendations on management of sleep disturbances in mild traumatic brain injury. Let me just prepare his talk.
Let me give you some absolutely very interesting data that will allow you to reconsider your whole concepts of blood pressure and sleep in the relationship to cardiovascular disease. There's so much confusion. Well, first, I will define the overlap syndrome. The overlap syndrome is the concurrent diagnosis of obstructive sleep apnea and chronic obstructive pulmonary disease. It may also entail obstructive sleep apnea with pulmonary fibrosis, cystic fibrosis, or other chronic lung diseases, but the proper combination is obstructive sleep apnea and chronic obstructive pulmonary disease. The term overlap syndrome was first used in this context by Flenley back in 1985. So it's an old term. Obstructive sleep apnea, on the other hand, consists of the word apnea from the Greek apneia, meaning no breath, defined as more than 90% reduction in flow for at least 10 seconds. An obstructive apnea is no breath with continued effort, central apnea without any attempt to breathe, a mixed apnea, one event with both central and obstructive components. This is scored as part of the obstructive apnea-hypopnea index, or AHI. Hypopnea is defined as a low breath, a 30% reduction in flow compared to baseline, accompanied by 3 or 4% oxygen desaturation or arousal. And the term RERA means a respiratory effort-related arousal. This is an exaggerated attempt at breathing with flow limitation on nasal pressure, accompanied by an EEG arousal with no desaturation or hypoxia. We define that obstructive sleep apnea-hypopnea syndrome as having at least 5 apneas and hypopneas per hour of sleep. This is called the apnea-hypopnea index, or AHI. This includes both obstructive and mixed apneas. And some overlap syndrome data is based on an apnea-hypopnea index of 15 or greater, moderate to severe sleep apnea. Some is based on home sleep apnea studies with what is called either a respiratory disturbance index, RDI, or a respiratory event index, REI, over 10 apneas and hypopneas per hour of study time, and this includes the very large sleep heart health study data. The term complex sleep apnea is the presence of both central and obstructive sleep apnea occurring in the same individual at the same time at the same night. So it's either primary, which occurs de novo right from the beginning without any intervention, or secondary, in which you have a baseline obstructive sleep apnea with treatment-associated central sleep apnea, or TEXA. And lung disease is not part of this complex. So complex sleep apnea has nothing to do with overlap syndrome. COPD, chronic obstructive pulmonary disease, is conventionally thought of as either emphysema, chronic bronchitis, small airways disease, or some combination of these, usually a combination of chronic bronchitis with bits of emphysema. I would like to distinguish the overlap syndrome, which is the topic of our subject of our talk today, from other newer terms that have come about recently, including the asthma COPD overlap syndrome. So some people have also referred to this as an overlap syndrome, but it is the asthma COPD overlap, not the overlap syndrome. There's no universally accepted definition. It is not a single disease or syndrome. It features chronic obstructive pulmonary disease with elements of asthma or vice versa. For example, emphysema with a reversible airway component. The term chronic asthmatic bronchitis was used in the past for this combination, where the endpoint, was the endpoint in the spectrum of asthma, from mild episodic asthma to chronic asthmatic bronchitis. But this is not the overlap syndrome. COPD definitions include the now most popular gold standards, and some of the data that we have on prevalence of COPD in China are based on the current gold standards, okay? Which stands for the Global Strategy for the Diagnosis and Management and Prevention of Chronic Pulmonary Disease. This is considered a treatable disease, but not totally reversible. The American Thoracic Society and European Respiratory Society have added additional data to say that it's primarily caused by cigarette smoking, and it also produces significant systemic consequences. Now, COPD is mostly caused by cigarette smoking. About 90% of cases of COPD are caused by cigarette smoking. And somewhere between 20 and 50% of all smokers will develop clinical COPD eventually, if they live long enough. Other factors are air pollution, occupational exposures to dust and fumes, including kitchens, and infections. Environmental factors and genetic predisposition, like alpha-1 antitrypsin deficiency. In patients with COPD, the forced expiratory volume in 1 second, the FEV1, declines by an average of 45 to 60 milliliters per year, as opposed to about 35 mils per year in non-smokers. But this can be as high as 120 milliliters per year decline in FEV1 in patients with COPD. About 4% of deaths in the USA are attributable to COPD. The prevalence in China depends upon the definition of COPD. Using spirometry to define COPD, the prevalence is about 8.6% overall in China, with larger numbers in certain parts, especially southwestern China. If you use the gold standard for defining COPD, the prevalence in China is 13.6%. The prevalence of the overlap syndrome is unknown in China, but it is known in some other countries. About 11% of patients in France with obstructive sleep apnea actually have also COPD, therefore the overlap syndrome. In one study done in the United States, the Sleep Heart Health Study, defining patients with obstructive sleep apnea, about 22% of those patients had concomitant COPD. So 22% of patients with COPD had obstructive sleep apnea or the overlap syndrome. A similar study in Milan had similar results. About 20% of sleep apnea patients had overlap syndrome. And in a study that was done in this little small state of Rhode Island in the United States, just looking at outpatients in clinics, they've calculated a prevalence of about 2% of overlap syndrome in about 10,000 outpatients in the state of Rhode Island. So we can say, I guess, we don't know what the prevalence is in China, but the prevalence of overlap syndrome in patients with COPD is somewhere about 20%. And 20% of patients with sleep apnea have the overlap syndrome. What are the consequences of overlap syndrome? The first and foremost is pulmonary hypertension. People with overlap syndrome develop pulmonary hypertension even with only mild airway obstruction. There's lower wake PO2 and a lower sleep oxygen saturation. There's more sleep disruption, a higher arousal index, a lower sleep efficiency, increased hospitalizations, more cardiovascular events, both fatal and non-fatal, and an increased risk of death. I'm going to show you why these things happen. The differential diagnosis, most importantly, would be obesity hypoventilation syndrome. Here you have to have a BMI over 30 kilograms per square meter, but usually it's 35 or 40 or greater. You may have abnormal PFTs in obesity hypoventilation syndrome, including some obstructive component and low diffusing capacity, but you don't meet COPD criteria. And there's hypercapnia out of proportion to the PFTs because of the reduced hypercapnic respiratory drive, and a smoking history usually less than with COPD. The treatment of overlap syndrome is first and foremost continuous positive airway pressure, or CPAP. This will increase survival and decrease hospitalizations. Oxygen will increase survival in those that are hypoxic with a saturation of oxygen less than 88%, and it will prevent pulmonary hypertension in these patients. The combination of CPAP and oxygen increases survival much greater than oxygen alone. How important is CPAP for the overlap syndrome? Well, this study done by Stankina in 2013 was a post hoc analysis of data based on over 10,000 patients for over a 3-year period. All had full in-lab polysomnograms with CPAP titrations. All of these patients were treated with CPAP, continuous positive airway pressure. None of them had bi-level positive airway pressure or auto-titrating positive airway pressure. The COPD was based on pulmonary functions with GOLD guidelines. There were CPAP data downloads to monitor adherence to treatment. And a supplemental oxygen was given for those that were hypoxic despite the use of the CPAP. And in this study, this is comparing the deaths that occurred over this 3-year period in those patients with overlap syndrome that either used CPAP, and here, those that were still alive, averaged CPAP use of 6 hours, and those that died averaged CPAP less than 4 hours. So if you used the CPAP, you lived. If you didn't use the CPAP, you died. Looking at everything with a univariate model, we can see that the important factors are CPAP and age, and down at the bottom is Charlson index. This is an index of severity of disease. But if you do a multivariate Cox proportional hazards model and take into account all of the varying risk factors, the only two factors that are important are the use of CPAP, hours per night, and age. So the severity of disease had no significance. So once again, what determined mortality, other than age, was simply how many hours of night you used the CPAP. This is clear in this study. In this graph, we can see time to death. The dark black area are patients that used the CPAP less than 2 hours. The next dark one up here is 2 to 4 hours. And then the very light ones that you can hardly see, and because there's no death, are the people that used it 6 to 8 hours. So if you use the CPAP, you didn't die. If you did not use the CPAP, survival was pretty bad. This compares to survival indices in obesity hypoventilation syndrome, which is the other sleep disorder that is associated with an increase in pulmonary hypertension. And you can see if you treat in this case the obesity hypoventilation syndrome was treated by non-invasive positive pressure ventilation or bi-level positive airway pressure, and it made the difference between death and survival. And here in this other study by Mucklesey back a while ago, again showing the difference in survival in untreated versus treated patients with OHS. So why is overlap syndrome so bad? Well, let me count the ways. But first, let's look at some physiology and then some pathophysiology. So respiratory function in non-REM sleep has mainly a metabolic control of breathing, with a lower hypoxic ventilatory drive in men, a lower hypercapnic ventilatory drive in men, periodic breathing at sleep-wake transition, an arousal threshold of about 88%, and an increased pulmonary pressure that's negligible of 4 to 5 millimeters of mercury. The minute ventilation is lowered by between 1/2 and 1.5 liters per minute, or about 15%. This is brought about by a decrease in the tidal volume in adults and by a decrease in respiratory rate in children. The PCO2 is increased by 3 to 7 torr. The PO2 is decreased by 3.5 to 9 or 10 torr. The minute ventilation, the oxygen consumption and CO2 production are both decreased by 10 to 20% in tandem. The net effect is a decrease in oxygen saturation by only about 2%, so it's negligible. Respiratory function in REM sleep, on the other hand, changes completely. The arousal threshold goes down to 70%. This is equivalent to an arterial PO2 of about 40 millimeters of mercury. A hypercapnic ventilatory drive is reduced by 67 to 86%. Minute ventilation is lowered like in non-REM sleep, but alveolar ventilation is reduced by 10 to 25% in phasic rapid eye movement sleep. There's asynchronous breathing, and there are central apneas lasting from 10 to 30 seconds. There is a circadian variation of lung function, like there is a circadian variation of everything else in the body. In even healthy individuals, best pulmonary function will be at about 4 o'clock in the afternoon, and worst pulmonary function is going to be around 3 o'clock or 4 o'clock in the morning. In people with lung disease, in this example, are people with asthma, there is a worsening. If you take people with COPD, even people that have a PO2 that is actually pretty decent, certainly above the level to need oxygen when they're awake, when they fall asleep, the oxygen level goes down. In this situation, W is wake, Q is quiet sleep, that's non-REM sleep, and then the last part, A, is active sleep. So what we're seeing here is a continuous decline in sleep in COPD patients down to very low levels when you get into REM sleep. And the PCO2 likely also will rise out of proportion in COPD patients compared to normal individuals. So even if it's in the 40s when they begin, it's up in the 50s when they get to sleep. That's without doing anything else. That's just falling asleep. So what does this mean? Well, it's illustrated by this study, which we did in my lab a few years ago. We took a number, actually 8 COPD patients that had moderate chronic obstructive lung disease, and but resting PO2s that were not needing oxygen, with saturation over 90%, and no history of cardiac disease, and no disease by echo or EKG. And we brought them into the nuclear medicine department put them to sleep under a gamma counter, and we did first pass and mug-up radionuclide studies of their heart to estimate right and left ventricular ejection fractions. And we moved all of our equipment from the sleep lab into the nuclear medicine lab and hooked them up for sleep studies and waited for them to go to sleep. And then we repeated everything during the first REM episode that showed more than 4% oxygen desaturation. So we repeated everything when they were hypoxic during REM sleep. And by golly, they all did become hypoxic. And then, because we were obsessive compulsive, in the morning after they were no longer hypoxic, didn't move, but now we're awake, we repeated everything again. And then we took these patients and we gave them oxygen, and we gave them enough oxygen to keep their oxygen saturation above 90%, brought them back into the nuclear medicine department and repeated all these studies all over again. So that was the study protocol. What we found was that the left ventricular ejection fraction didn't change during hypoxic sleep or in the morning. But what happened was, even though for the most part, that one study in the middle of the night didn't show much of a drop, except for this one patient who seriously decompensated and had to be taken out of the study. What happened was, in the morning, most of the patients were very decidedly affected by this all-night hypoxemia and had a reduction in their right ventricular ejection fractions, but not their left ejection fraction. This is illustrated here. Patients at baseline with a RF around over 45%. During hypoxic sleep, no significant change, but in the morning when they were awake, no longer hypoxic, saturation 92%, the right ventricular ejection fraction was significantly depressed. Why was that? Well, it turns out that if you look at the hypoxic scores, the amount of time spent below 88%, the patients that decompensated and had a reduction in right ventricular ejection fraction had more time that they were hypoxic below 88%. It's illustrated here in these two graphs. Those with the decrease in RVEF, more than 2 hours with saturation below 88%, and those without a change, 20 minutes. Gave them oxygen, brought them back, and no longer was there any change in right ventricular ejection fraction. This is illustrated in these sides. Nocturnal hypoxemia, RVEF, base supplemental oxygen, no change in RVEF. That's the right side of the heart, right-sided pressures, pulmonary hypertension, and right ventricular disease. Now, this is somebody not with COPD, this is somebody with just plain obstructive sleep apnea with an arterial line in, and this is the systemic blood pressure corresponding to the hypoxemia and the arousals that are occurring during each episode of apnea. Why is that? Well, it turns out that in patients with obstructive sleep apnea, unlike those COPD patients with sustained hypoxemia during the night, there's intermittent hypoxemia. The obstructive events with the intermittent hypoxemia wind up with enhanced sympathetic tone and directly from the hypoxemia in the carotid bodies, and because of arousals that result from the recovery from the sleep, from the apneic events, resulting in enhanced mean arterial pressures, systemic arterial pressures, and this increase in sympathetic neural activity persists even during wakefulness. So obstructive sleep apnea, the nocturnal episodic sympathetic activity is the most important factor in causing hypertension. It's quantitatively linked to diurnal blood pressure. Intermittent hypoxia and reorganization causes systemic hypertension, but sustained hypoxemia causes pulmonary hypertension, not systemic hypertension. There are intrathoracic pressure changes, inflammation, and then this is inflammation in obstructive sleep apnea secondary to the cyclic episodic hypoxia and reoxygenation mediated by NF-kappa B. So we can sort of synthesize the relationship of blood pressure and sleep disordered breathing in the following way. Intermittent apnea caused by airway occlusion results in acute nocturnal blood pressure rise and eventually sustained daytime hypertension. The recurrent arousals without airway occlusion do not result in hypertension. Sustained hypoxemia results in pulmonary hypertension, but not systemic hypertension. And only the asleep blood pressure is correlated with the risk of cardiovascular disease. These are the results of the HYGEIA study done by Ramon Hermida in Spain, and we talked about those the last time that I spoke to you folks. The relationship then of overlap syndrome and cardiovascular disease is a very strong one. There's a significantly higher risk of hypertension compared to just COPD alone or compared to obstructive sleep apnea alone. There is an increased risk of peripheral vascular disease compared to obstructive sleep apnea. And there is an increased risk of pulmonary hypertension, both compared to COPD and especially compared to sleep apnea alone, the odds ratio of 5.93. Here are the data to support that. This is looking at the overlap syndrome and systemic hypertension. So the systemic hypertension versus in the overlap syndrome versus just COPD alone, significantly greater with the odds ratio of 1.68. And the odds ratio of 2 for developing systemic hypertension versus obstructive sleep apnea alone, twice as likely. So we know obstructive sleep apnea causes systemic hypertension. Overlap syndrome is twice as likely to cause systemic hypertension. And worse, we're going to, as we can see, that is going to take its effect at night. Pulmonary hypertension is the big one. The development of pulmonary hypertension is almost 3 times greater in those with overlap syndrome compared to those with COPD alone. And it is almost 6 times greater in people with overlap syndrome compared to sleep apnea alone, because sleep apnea doesn't cause pulmonary hypertension by itself. So the cardiovascular consequences of overlap syndrome are sustained hypoxemia causes pulmonary hypertension and right ventricular dysfunction. That's what you get from COPD. Intermittent hypoxemia with arousals and increased sympathetic neural activity causes systemic hypertension and left ventricular dysfunction. That's what you get with obstructive sleep apnea. So overlap syndrome results in both of these. I would be happy to take any questions.
If we have any questions, please just send it to me and I will get Dr. Castriotta to answer them for you. Also, those online, please write down in the chat. In the meantime, let me just prepare for the next talk.
and therapies. So please welcome Khem.
Good morning, everyone. Again, for the third time. Good morning. No caffeine yet? Good morning. I'm so excited today, especially this morning, because I'm talking. At least one person is excited. But I appreciate you coming in and supporting NAPS. Also, those that are online, I want to just shout out to Alden in UAE and the rest of the attendees. So my topic today, we switched a little bit. I hope you don't mind, but I'll be speaking on new diagnostics and therapies. I will touch on a few other items along the way, but hopefully this will be beneficial for you. Oh. All right. So the scope of my talk will involve a quick look back, a little bit of history, then the current therapies we have, the most common disorders, the challenges that we have, and how things are changing. And then, of course, options, compliance, and then I'll be showing some or explaining about the new therapies. Actually, let me get my paraphernalia. But before I begin, how many of you here have been in sleep for a year? 1 year. Anybody new in sleep? Come on, raise your hand. 1 year? Good. How about 5 years or less? 5 years or less? How about 10 years or less? Okay, a few more. And 20 years or less? Okay. 30 years? 30 years or less? Glenn? Oh no, he's over 30 years. Sorry. So as you can see, we have a variety of people who's been asleep. And so my topic today is to consolidate that idea, because of course there are new to sleep and there are those that had been in sleep for a long time, but the perspective now is changing simply because of the new technologies that are coming in. Just because you're new in sleep doesn't mean that you have a long way to go to understand sleep. And that's what I'm trying to get to. Okay. All right. So one of my 3 goals are understanding where we were and where we're going as clinicians, and then what the paradigm shift is happening right now and how the future looks. This clicker is not too friendly. I feel like Michael Jackson. All right. So in the meantime, the premise is, what are the most common disorders that we have? Of course, you have the upper airway obstruction, insomnia, EDS, and movement disorders. Dr. Castriotta's talk earlier was mentioning about overlap syndrome, or COPD, that has both the upper and the lower airway obstruction. All right. And the current therapies that we have are these. The infamous CPAP, known in some areas in the US, or CPAP, or PAP therapy altogether. We have the oral appliances for CBTI, as mentioned by quite a few presenters yesterday. Then you have surgical interventions, and then pharmacotherapy. And here's a quick history session. It won't be too long, maybe 2 hours. All right, 1953 is the discovery of REM by Eugene Arthurinsky and Dr. Kleitman. Further on, discussed and researched by Dr. Guilleminot and Dr. Dement, who are known to be the modern sleep medicine fathers, right? Father of sleep medicine. 1978 is when, 1978 is when the American Sleep Disorders Association, now the AASM, is founded, making the formal recognition of sleep medicine as a specialty. And then in the 70s is when the establishment of the first sleep disorder clinic was formed. And then in the 1980s, an introduction of the PSG, which is the actual comprehensive study now of sleep. And this a comprehensive sleep study tool combining multiple parameters or physiological movements, as we all know, okay, and such as the brain waves, the EEGs, EOGs, etc. Then in 1981, first clinical description of OSA was made. 1981. You're not gonna know. And so looking at the old systems, this one right here is not a torture machine. It's an old PSG and an EEG machine, right? As you can see there, those notches and swivels, those are how you actually manipulate the voltages and the frequencies and the settings. The bottom here, right? You can see that these are pens. Okay, these are pens. Underneath there's a little straw-looking thing, and they go into these vials with ink in them. So you have ink, you have this, it sucks out the ink, and then it goes onto the pen. Remember Rebecca's talk yesterday when she was talking about the deflection, you know, the square wave calibration? That's why that was done, because you have to calibrate how the pen deflection goes, whether it is on the vertical or the horizontal axis, and also the time constant, okay? Now you can see why, all right? So it wasn't easy, and once you're done with your study, you are done. You cannot edit, you cannot change montage. That's it. If you fell asleep, if you're in RAM while doing the study, your study is stop. So anyway, then it ended up being developed into the digital format. So in the middle, that's digital format. Actually, when I finished school in 2000, and I was still working for another lab that we dealt with the paper machine. And so when I started doing things in the computer digital format, it was so weird, because at first we were doing things in DOS. Anybody know DOS? DOS? That's how we were changing, manipulating signal patterns and filters. You go to command prompt and you change. All of a sudden, you just click, 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 click. It was a weird experience because it was too fast. I was like, it's done? That's it? That means I can sleep more. And now you see some of the new PSG systems is super tiny, right? And it just requires a laptop. Now, outgrowing the lab, in the 1990s, there's an expansion of sleep medicine beyond the in-lab testing. And that's what we know now as your OCST or HSAT, HST, right? Out of center, home sleep testing device. This became more convenient and increased more access to the patients, because now sleep is growing. You're seeing more patients. Now people are becoming interested in getting tested, but when they see the machines and all the electrodes, they get scared. All right. So there was a study in around 2006, this device called micromesem. Micromesem study is now what we know as the apnea link. So at first that was used as a screener, simply because now the field is growing, you have more patients, but now there's a funnel, right? Then there's a lot of patients trying to come in to get diagnosed. And so a screener was created to make things simple, right? We used to use actigraphy. We used to use oximetry just to screen patients, because we want to make sure that before we schedule the patient for an in-lab testing, we have already have some ideas that, yeah, they might be positive. So we start to filter those that are truly negative, at least on the actigraphy and oximetry wise. But micromesem, the apnea ear, was a screener because it offered 3 channels, right? It has an oximetry, it has a flow, and then it has a snoring. There's no belt yet to monitor effort. But then when it got approved after the research was done that it was actually comparable to an in-lab testing, it was well over 80, 86%, very close to how we can identify OSA. So it was then approved by the FDA to move forward as a diagnostic tool, okay? All right, that's how it looks like. This one, that one looks like night one or PDX. Anybody recognize that one? Is that a PDX or night one? Interesting. Oh, sorry. All right. Now, in 1992, there's an approval of CPAP therapy for OSA. So this truly revolutionized the treatment options. It started the race also for developing more PAP modalities. Exciting event. And then 1999 was the introduction of the ESS, the Epworth Sleepiness Scale. All right, and these are some of your PAP devices. They're becoming smaller and smaller. Maybe sooner or later, it'll be integrated with your phones. And then in the 2000s, recognition of the link between sleep disorders and the other medical conditions such as CVD, diabetes, and obesity were recognized. Then in early 2000, you have more development on pharmacotherapy. FDA approval of modafinil for the treatment of excessive daytime sleepiness associated with narcolepsy was introduced in the market. All right, now how do we do things? Let's switch gears. With therapies, of course, when you have OSA, you go for PAP therapy, right? You go for CPAP, APAP, bilevel, auto bilevel, right? Okay? We don't really use ST mode for just OSA, right? Or ASV. Then insomnia, you have CBTI and medications. And then excessive daytime sleepiness, same way, medication, CBTI, and then movement disorders with medications. Now, what are the challenges with the therapies? One, and the biggest, is compliance. Why do you think compliance is important? Why? Why? Well, for one, at least in the US market, compliance is important because it's pushed forward by the payers, by the insurance companies. The insurance companies dictate what really happens, right? If the patient is not compliant, they will not pay for the intervention, for the PAP devices, okay? So everything is about compliance. It's a good thing, right? And then the other challenges are, you know, the therapies, CPAP, they used to be bigger, okay? They're big. At nighttime, you can use them as CPAP. In the daytime, you can use them to clean your room or take out the grass. And then it's also very human resource heavy. You need people. Before, When patients have been diagnosed, then they move to the distributor, or we call them the HME, DME, durable medical equipment, or home medical equipment. And they're the providers or the suppliers of the devices, okay? Now, they used to have respiratory therapists to go into patients' homes, all right? I did that job. I'm not an RT, but some states allow for non-RTs to provide the CPAP devices or the PAP devices, educate the patients, but we go to people's homes. And some homes I wish I've never seen. But it's very heavy. And so it was okay before, since they used to pay really well. And the insurance companies pay really well. And then you also have an issue with abuse, because sleep before was not regulated. Okay, so I'm explaining this now because this could happen here, right? Once sleep becomes more developed, once you see more patients, and then of course what comes after are the regulations. Before, any doctor can open up a sleep lab. In fact, I have one short story, 30 minutes. I saw this ad on the newspaper. Yes, newspapers were real. You touch them, hold them. Now it's just you swipe. Okay. But I saw this ad for a sleep tech. Oh, close to my house. Well, my mom's house. It wasn't mine. I live in the garage. But I got off that morning, had my jeans, rubber shoes, t-shirt, and I wanted to see where the lab was. And I saw it was nearby my house. I looked inside and somebody saw me and asked, "Hey, come in." I said, no, I'm just stopping by. But she forced me to come in. I said, no, come in. What do you need? So I told her I was a sleep tech and I saw the ad. Her name was Mary. I remember her. That was a neurology clinic. And she said, "You're a sleep tech?" She was so excited. "Let me call the doctor." I said, no. I don't want to present myself like looking like that, with just, but anyway, she called the doctor. She presented herself. She was wearing a very nice dress. And she was excited. Immediately, she said, "Come on back." So she showed me the EEG systems, and then she showed me the sleep system. Needless to say, she offered me the job right there. I took it. It was good money, because it was really good money back then. I started doing sleep for her a few nights a week. And then I asked her one day, "Hey, doc, we have some positive patients. Also, where's your report?" She said, "Don't you know how to write reports?" I said, "I have a template at work." So I used the template and she just signed everything. Anything I said, patient's crazy, put them on whatever, she will sign it. She just signed everything I did on a report. So after that, I asked her one day again, "Hey, doc, where do we send the patients for CPAP?" And she looked at me and said, "CPAP? What's CPAP?" So my vision got dark and tunneled. I realized then what she was doing. That was the abuse back in the early 2000s. Anybody was opening up a sleep lab. Anybody. Even those that don't know what sleep is. It's a long way, but I made money from her. Anyway, after that, I trained my buddy in there who was a barista, and now he runs a 10-bed lab. He even told me he wants to hire me as his tech. What an ingrate. Then we have issues also with coding and reimbursement challenges, because they were not completely designed, right? When you develop a market, so sleep here, once it becomes bigger and bigger, you'll have reimbursement. You will talk about coding a lot, because things will become more streamlined when you code. When you submit a report to the insurance companies, it will be just in codes, okay? And that will have explanations on how things will get reimbursed. And the biggest issue too is that everything was fragmented. You have neurologists doing sleep studies. You have ENT now doing sleep studies. You have pulmonary now coming in and taking over the whole business, right? You have psychiatry and everything else. Dental sleep has been around since the 80s also, but they were very smart. They stayed under the radar. So they were not regulated for a long time. All the other operators of sleep, the MDs, they became regulated ahead. And dental sleep was just coasting. What that meant was that the dental sleep practitioners, they get paid really, really well for a long time because there were no restrictions yet, not much regulations. I can tell you, like, there was a dental sleep doctor that I worked with before, and she was billing quite a bit, well over in the $7,000 to $9,000 per bill. That's pretty good money. Anyway, moving forward. Well, and now what's the changing landscape in sleep, right? Within the last decade, there's several technological developments, right? And this truly made a big impact in how we see sleep. For one, wearables. Now, wearable sleep tracking devices, they're all over the place. I'm wearing one right now. I'm sure you are too, right? So these things, smartwatches, fitness trackers, they have accelerometers and they monitor everything, heart rate, even your location. They might hear you. I don't know. But these devices provide insights into sleep duration, quality stages. Many of these smartwatches now can tell you, right? Did you get REM or non-REM? Tells you. So very interesting. All right. I think when I click the signal, it goes to Mars and then back. There. All right. Now, digital health and newer HSTs. In the 2010s, integration of telemedicine and digital health tech into sleep medicine was started, allowing for remote monitoring and diagnosis of sleep disorders. Who does telemed now? Anybody do telemedicine here? No? So in our practice at USC, we see at least half of our patients telemedicine. So they could be somewhere. They could be in Mars and be seen. I think the one in Mars is Elon Musk, by the way. And in 2015, there's the introduction of the technology called PHAT, peripheral arterial tonometry. I have a sample. I'll pull it out later. It's right here. But this device is also for home sleep testing, and now these things are more convenient, even more so. Oh. All right. 2017, FDA approval of the first medication, which was indicated for the treatment of EDS in narcolepsy patients. 2018, getting closer to us now, was publication of the American Academy of Sleep Medicine's clinical practice guidelines for the diagnostic testing and treatment of sleep disorders. And then there was COVID. Killed my business. That's another note. And then 2020, there was a growing recognition of the impact of COVID-19 on sleep patterns. I think it was Dr. Hibunada that talked about COVID-somnia. Very interesting talk. And in 2021, advancements in wearable sleep tracking devices and smartphone applications for sleep monitoring and management were introduced. In fact, the Samsung just recently released their new app. You guys heard about it? They have it on the Galaxy Watch, but it's an apnea tracer app. Actually, it's a pretty good app. I was once a part of the clinical team that looked into the PSG and compared some of the data. Okay. All right. More options, answers, and compliance. All right. This is the new era, right? From the wires now to unwires. Now everything is starting to become different, even not just on the size, the look, but how things are managed and implemented. All right. And more research that are going into genetics. There is an ongoing research on genetics, neuroscience, and physiology of sleep. So as the development of personalized approach to sleep medicine and patient care continues. There's some, one of the doctors yesterday, I think Dr. Say mentioned about, now is more, everything is patient-centric, so everything is individualized. The other presenters also mentioned that. Everything is individualized. It's designed for you. I think Dr. Lay also mentioned same thing. So it's not just one all be all, it's not generic. Everything is very much specialized for you, right? Okay, and there's more genetic research that looks into the biomarkers. These ongoing research into the genetic basis and biomarkers of sleep disorders aims to elucidate underlying mechanisms to identify at-risk populations and develop targeted therapies. And of course, the infamous AI. Every day, everything's about AI, right? Even my car, I'm driving and of course, you're not perfect. You're not always in your lane. I wasn't texting though, right? I was just watching a movie. But you get off a little bit, it pulls the steering wheel. It moves my steering wheel. It's scary. And now, in fact, I didn't mean to digress, but there's more technologies that are going to be built into the paint, right? Into the road signs. There will be sensors on the road so that the self-driving cars will be even more efficient and effective. Anyway, back to sleep. Now, artificial intelligence and machine learning are being increasingly utilized to analyze large data sets. Okay. And from sleep studies, identify patterns, like Glenn mentioned yesterday, pattern recognition. I guess sooner or later, Glenn will be AI'd. And also this assists with the diagnosis and management of sleep disorders. There are AI-driven tools that have potential to enhance the accuracy and efficiency. So accuracy and efficiency of sleep disorder detection and treatment or the decision-making. It's quite scary, but for those who are not trusting this yet, right? But we have the AASM supporting this now, right? AASM very supportive of the AI development in scoring. In fact, they already have announced the recommendation for, I think, ENSO data or approval, ENSO data and Somnolizer. Somnolizer has actually been around for a few years. It's with Philips. But before, if you want to use it, you pay. It's like $10 per study. Don't quote me on it, but I remember hearing about Somnolizer. So if you think about it, like there's so much data now, so much data. And so these AI and this machine learning, they study. But when they study, they exponentially increase studying in just a matter of days and months compared to human beings. So they have gazillions, trillions of data that they can sift through, they can go through super quickly, okay? So as you can imagine, the landscape is definitely changing. You know, we talked about the heavy human resource type of sleep medicine that we have. It's changing. You can see it now. There's many labs that closed, right? In the United States, there used to be thousands of labs, and now they start to close down, right? Not only because of AI, of course, but yeah, it's a big part of it because the home sleep testing devices, they can even auto-score, right? Of course, we have to validate it as clinicians, but they can. You're not talking about 0 or 50% capability to identify hypopnea and apnea. No, it's higher percentage than that. These devices are very, very smart, and they only get smarter by the day. All right. Now, digital therapeutics. There's also the development of digital therapeutics. Phone apps, web-based programs for the management of sleep disorders, and has expanded the treatment options. These digital interventions may include CBTI, relaxation techniques, sleep hygiene education, and guided meditation. And this provides patients with accessible and personalized support. Have you guys done the Calm app? Calm app. It's embedded into my my Outlook. So after a few hours, it will ping me, Khem, and they'll give me an option to do it or not, and I do it. I don't use it to take a nap at work. I'm just meditating. So if my boss walks in, I'm just meditating, even though I'm snoring. So it's quite interesting how things are even becoming more personalized, but are now accessible, not just in the clinic or clinical areas, but also at home, right? And telemed and remote monitoring, and these are the integration of telemed platform and has facilitated remote consultations, follow-up visits, etc. Patients can now access from the comfort of their homes, leading to improved access to sleep specialists and continuum of care. Does this sound good or not? Do these sound okay or no? Can you hear somebody say okay? Nobody will get mad if you say no. So just with everything, there's pros and cons, right? What do you think is the cons for telemedicine? So yes, you have access to care, but by golly, some of the patients, when we call, they're ready, they're not even dressed. Like not dressed, very inappropriate, okay? Some of them driving. Come on, you can't drive and then be seen by a doctor. But so things have to be regulated again and again and again, okay? So there's always pros and cons. It did increase the access to care and personalized medicine. There's not much wait. Imagine you have 100 patients. You want to see them today? Okay. All right. Now there are even robots. Robots has an iPad or a tablet, right? Now I say iPad for everything. Just like saying, can you get me a Colgate instead of saying toothpaste? Or I want a Coke that's orange. But now they have these robots in some clinics. They exist now. And these robots will go see a patient, right? Or will go to the doctor and the other patient on the other side. So the doctor could be somewhere in Mars or in Haiti, but they can see the patient because this capability is now becoming to not infiltrate, but to become widely used in the market of medicine. Okay. Now, before it was mainly the primary care physicians that see a lot more of these patients. Now patients can get seen more into the specialized care, such as sleep, right? Now, what are the choices for diagnosis? Before, as you saw, this big, bulky things with pens and wires and sensors. Now you're talking about little things, little gadgets. These are some of the diagnostic tools. Can you imagine that? These are diagnostic tools that can identify apneas, and some of them can identify central apneas. Some of them can identify oxygen desaturation, snoring, central. It's quite crazy. Let me show you a device. For those interested, this is $3.99. Oh, give? Oh, 3,000. My price increase. More demand, higher the price. So I don't know if the online people can see, but this is actually brand new. The rep showed it to me. I gave him a donut and he gave me his sample. What do you think is this? What do you think is this? There's something you balance? This is a home sleep device. So you put it under the chin, you tape it, and you go to sleep. So it will monitor oxygenation, will monitor AHI, it'll monitor REM versus REM, because it senses also the muscle tone of the jaw. Pretty crazy, right? What happens in REM? Glenn asked yesterday. What happens in REM? Yeah, so muscle tone drops and maybe apneas occur. When apneas occur, patient wakes up, the tech wakes up too. But imagine this thing. It's different when you see it in slides versus you see it in person, right? I feel like I'm marketing for them. But it's pretty crazy how far we've come. All right? Now that's one. It's another one. This is also brand new. This one's $12.99. $15.99 if I sign it. Like an autograph demo unit. So this device is a real device. I've used one. This is a new one. You put it on, you have put on your finger, and this goes on your chest, monitor effort. So you can have central recognition. Pretty crazy? That's not the craziest part. This uploads to the cloud. And the crazier part, you throw this away. You do. This is watchpad. This is one. Means used only once. And you throw it away. I will keep this so I can attend those parties with costumes. Now, that's real device. And then we have gone through other types. The one on the top, oh, the next one. So not only are they small, but they use the cloud. So there's no going back to your lab or to your distributorship to download data. It's automatic, right? It's bizarre. So this thing right here, I've used it too. I went to a lab in 2022 for a few weeks, looking at the download of this device right here. This thing right here. Very tiny. But they actually pick up ODI, AHI. Pretty crazy stuff. This is bought by ResMed. This is a Belgian company. And now, right before I left the US a few days ago, there was somebody that connected with me on LinkedIn and has asked me if we can meet. They want to show their product. This product, right, is pretty crazy too. This is just a band, but it will identify the different sleep stages. And it also has an audible therapy, it has sound, right? You won't be like, no. It will be like something more calming, like maybe like I don't know what it is. You don't want me to sing. I will charge extra for that. But from this is not just, this is already going into treatment, not just in the diagnosis part, right? All right, so, whoop. We were talking about the diagnosis, and now all right. And now let's talk about the choices for intervention. All right. Now, before we have PAP therapy for OSA, right? For obstructive sleep apnea, you use CPAP, you can use bilevel. When do we use bilevel? When do we use bilevel therapy with OSA? So you can use bilevel if they're non-compliant, right? They can't use CPAP, very uncomfortable, or you are increasing in pressure and they're still having apneas after 15 centimeters of water pressure. You can switch them to bilevel, right? You can also use auto bilevel. So these devices now, they monitor flow limitation, apnea, snoring. They can even monitor central. So these auto devices, their algorithms are very, very sophisticated, right? Now you have also more complicated patients, like complex sleep apnea or TEX, treatment emergent central sleep apnea. You have overlap syndrome patients. You have patients with neuromuscular disease and sleep apnea. You have one of the physicians mentioned yesterday was COMISA, complex insomnia. You have a lot of complex, like mixture of diseases or disorders. But the mode of intervention is also mandibular repositioning device, which I think Dr. Tuazon will talk more about later. Then you have positional device that was mentioned yesterday by one of the presenters. And then, of course, surgical interventions. There's a whole nother list of surgical interventions, okay, for apnea. And then the new things now to pharmacotherapy. Does anybody remember the medication that has been moved forward to treat sleep apnea? If not, we'll Google it. But it's coming out. All right. Then you have implantable devices and neurostimulation devices. You have EPAP. Then this EPAP is not part of a device, a bilevel device. And then you have oral negative pressure devices. Let's see how they look. Three hours later. All right, this is the EPAP. No, this is not toilet paper stuff in the nose. This is actual device. So these devices, they are meant to create positive pressure or external positive pressure, right? So I've used one of them. Where'd that go? I've used one of them on the plane the last 2 months ago. 2 months ago, I used an EPAP on the plane. But let me move this forward. That one This one creates negative pressure. So you have the eye nap and winks, but you put this in your mouth like a mouth guard, and it has a straw, and this straw sucks very low pressure to pull your tongue forward, right? So you're sleeping with just a straw coming out of your mouth. Some of you might already do that when you sleep and eat. No, okay. This one, sleep and drink. Is there one, Glenn? Is there a problem with the sleep drinking or no? I think the sleep drinking are just alcoholics. All right. Now, some examples are, there's also now neurostimulator or neurostimulation devices. And some of these devices, I'll show you an example. All right. And this is one of the devices that has been in the market for a while from UK. But this device looks like a Y, or in Tagalog, do you know tirador? Looks like that. It's like a slingshot. Looks like U-shape. You put it in your mouth and it sticks out because the one at the bottom right here, that's the battery. All right, that's the battery. And this thing, it has 4 electrodes. No, 4? Right. 4 electrodes, all right? They are focused towards the genioglossus muscle. So they stimulate you. They give you a zap, all right? So you don't talk when you're doing this. It'll be a weird conversation. But it changes the voltage and it changes the frequency. So it starts at 3 hertz, then 10 hertz, 3, 5, and then 10 hertz, then 20 hertz. Okay, and then you can increase the voltage. You use an app to increase the voltage. All right, so don't do this when you're arguing with your spouse or with your significant others. But anyway, the point of this is it's a daytime therapy. You use it for a few weeks, every day, just 20 minutes. And it works out the tongue, particularly the genioglossus muscle. A clinical study was done in UCSD to show and to identify the types of muscles and what changes occur, right? From that study, it was with Dr. Malhotra. What he explained was that OSA patients' muscle are very strong, right? See, OSA patients, who's OSA here? No, I have OSA, severe too. But anyway, I have strong muscles. I mean, the tongue is very strong, but they don't last, okay? The tongue becomes flaccid, like soft, quickly. As soon as you fall asleep, yep, there it goes, blocking the airway. But then people without sleep apnea, their tongue muscles, the tissue fibers of the tongue, their tissues are not as strong, but they can last tonicity longer. So they can last. So if you compare into an analogy, one is a bodybuilder, right? And one is a marathon runner. The bodybuilder can be, or a sprinter. You've seen sprinters, very strong, powerful looking people. But then you have the marathon runners, usually very skinny, right? But that marathoner can run forever, from here to Mars and back, right? So that's the difference between the OSA and non-OSA patients based on that study. So this device, that's what it does. It will change the physiology of that tongue. All right, that was a cue. It says stop talking. But to think that it can reduce AHI, ODI, and snoring is pretty interesting. Okay. Now here's the device, and you can control it with your app. All right. Now, no, I won't answer questions yet. Yes. All right. Sorry, it's taking a while to click. It's not moving. Okay. Oh, thank you. And now you have the implantable devices. So there are implants for OSA and there are implants for central apnea. But the device for the obstructive sleep apnea stimulates the hypoglossal nerve, whereas the device for the central apnea stimulates the phrenic nerve to stimulate and move the diaphragm. So both have different uses and indications. But to give you a perspective, patients can have a mask and a machine, or they can have this implant. No, this is so this is the implant for the central apnea, and this is the implant for the obstructive sleep apnea. Quite amazing how they're tiny, and then they treat our patients, right? Just like everything else, it has pros and cons. Some patients can tolerate the stimulation and some cannot. The main thing, though, is that it's already implanted under their skin. So when they want to get rid of it, it's not that easy. They're also very expensive. They're well over $35,000, $70,000. It's pretty expensive procedure. But in the United States, like this particular device, they are reimbursed by the insurance companies. All right, moving forward. Now, these devices, some actually start on their own, but some will have to be activated when the patient lays down. So this one is for the obstructive apnea patient. When they lay down, then they put this on and it activates the implant. The other one, as soon as the patient lays down, it activates on its own. So sometimes it gets activated without them wanting it. Now, there was a patient that we had an issue with because, you know, for the obstructive apnea, what happens when the stimulation starts, your tongue protrudes. You go like that. So if the stimulation is too strong, and then that's how the action is, the mechanism. It's funny. That's why you only do that when you're sleeping. All right. And then this is the tiny part for the central apnea device. All right. This is the one that creates a negative pressure. You put it inside your mouth and it creates a negative pressure to move your tongue forward. And then the same thing for this device. Those pros and cons. The salivation is always the issue because you have something in your mouth. So you tend to salivate. And then you have these devices. These are the EPAP devices. So this is the one I used on a plane. So you stuff it in your nose and it comes in 3 sizes, right? You should like do your own, you do your own sizing. Don't let anybody measure your nose. They might use their pinky. Okay. but you have 3 sizes here, and there's a strap that goes around your head, and then you just stuff it in your nose, right? So I was a little embarrassed because I was on a plane. And I admit I snore even standing up. My daughters will tell you that. But I was on a plane, I was falling asleep. I was tired because Glenn kept texting me. No, I'm just kidding. But I stuffed my nose and I put my mask on so they can't see it. I actually fell asleep for 4 hours straight, which was weird for me on the plane. So I don't know if it works or not, but I fell asleep with it. Interesting. And that's not me, but that's how I kind of look like without the hair. So how these devices work is that when you put it on, they have valves. When you inhale, the valves open so you can inhale. But when you exhale, the valves close, right? The valves close because you're forcing the air out. So when they close, it creates the pressure towards the back of your throat. When we ask the rep, how high of a pressure is that? Because we've never tested it ourselves, but they claim to have at least 8 to 12 centimeters of water pressure. Pretty high, right? So it'll be nice if we can, test it out more. And this I've done titrations with. So this is similar to the other device, but this one used to come with a cannula. The ones for the sleep lab, it has a cannula here connected to both, and then the cannula joins and ends up on a lure lock, right? It looks like a lure lock, and then you can attach that to your pressure transducer sensor, so you have flow, so you can see the flow pattern. And we used to do a split night with it, and there are patients that reacted positively. They have lower AHI, some snoring were reduced. But that one, we've actually tested it. The other one, no. The problem with this is you have to buy this. It's a sticker. So you can't keep reusing it. And you can't use super glue. Then it'll be permanently in your nose. It's not going to look nice. Are you all okay? Still awake? Okay. I'm about to get quiet now. I'm almost done. All right. See this right here? This is what I was talking about. So we were able to test if it was working or not, because the first part of the study is without the device, and then the second part with the device, and we have the thermistor. You can just stuff the thermistor in there, or you just stick with the PTAF flow, and you will see, and you can compare the diagnostic portion versus the one with this EPAP device and compare the AHI or snoring. All right. Now there are more innovations like the beds and mattresses. You have sleep monitoring, smart beds and mattresses, and they have embedded sensors and technologies within the mattress itself, right? They can identify body movements, positions, respiratory patterns, but they are not, from my understanding and from those that I've looked at clinical study-wise, they're not out in the market. I don't know one that's already publicly or being used right now. I think there's still some ways to go, but this technology they have started developing this years ago. Minimum 10, 15 years, they've already started trying to develop these things, right? Now, smart beds, they have embedded ballistocardiography. And together with network connectivity, signal processing, and machine learning, they detect heart rate, breathing rate, and sleep versus wake states. I see the sleep test getting sad. Don't worry, we still have jobs. Okay. I started practicing how to dance for future change in careers. Cultural dance. Okay. Now, why is there a need for new therapies? Right? Because we talked about it earlier, the issues with compliance. These therapies have pros and cons. PAP therapy, the attrition rate, people that quit PAP therapy is still up there. Minimum 50%. There's a lot of clinical studies that will give you different percentages. But for the most part, we're not at 100%, right? We're not even 80% compliance with PAP technology. So it's not going to change soon. It will just probably get modified, more sophisticated, better, more comfortable, right? But the issue is compliance simply because if this market here develops and it becomes regulated, then you have the government paying for it or the insurance companies pay for it. Insurance will be your next big activity, right? Right now, you're cultivating sleep, the knowledge of sleep, the diagnosis, the interventions, or the treatment. Later on, it will move towards compliance, regulatory actions as you develop your market in sleep. Now, effectiveness of these new therapies is still too early to tell. Some had been around, like some of these devices have been around well over a decade, and they just now penetrated through the market and started being sold, right? But clinical studies are available, so they do have studies. Some are not meta-studies. Like the one I mentioned to you about the tongue physiology, right? With the intraoral neuromuscular device. They have, that one study has 20 patients. So it's not a big study, right? But they have more clinical studies. FDA approved, now there are more devices outside of the United States, but to go through and get into the US market, it takes a long time because of FDA approval. Yeah, they have to go through a very rigorous pathway to get approval and get into the US market. So there are definitely devices out there that we haven't even heard of yet. They're just not being used in the public market yet. And then there's the issues with insurance companies. So I do mention insurance companies because this will affect how we practice as the bottom line. We are all clinicians here, but we are all affected by the insurance companies and how they deal with our patients and reimbursement and all that jazz. Okay. And lastly, still requires pre and post installation studies. What does that mean? Right? So when you put the patient or you get the patient diagnosed and then you put them on a new therapy, it's not as easy as that. Right? The pathway is that usually you put this you get the patient diagnosed, then they go on PAP therapy if they have OSA. If they fail, then you have the option to use another intervention, right? So it's not just getting the patient diagnosed and directly into a new therapy. No, there's regulatory compliance that needs to be met. All right. All right. Now, pros and cons, just in a nutshell, we've already discussed. The pros, of course, are new options for non-compliant patients. Before, when your patient cannot comply with, say, PAP therapy, because OSA patients are our biggest number of patients. They envelope the majority of the patients we have. Yes? But when they become non-compliant to PAP therapy, many fall through the cracks. They're not seen anymore, or they will not go back. They won't go back to the doctor and say, hey, can you still help me? Can you still fix me? I can't deal with this, right? Many patients just, I can't use this machine. I just use it to keep my door open or dry my car, right? So with the new therapies, there are more options. Insurance now have accepted many of these things. Some are still cash pay. So in this country right now, everything is still cash pay, right? But it will start to change because some of the other countries like Korea, Philippines, at least the insurance companies and the government start to help pay for the testing and also the diagnosis. It's meant to happen, right? And then because of that, you can capture more patients and put them into another type of therapy to try to help them. And sometimes helping the patient doesn't mean you drop the AHI to 0, right? It's even impossible to drop the patient to under 5 if their AHI is 200 or 150 or 80, right? If you drop the AHI to just a good 70, 80%, that patient's already giving you gifts, all right? Because they will feel a difference when they get into therapy. Now, simple, even if surgery is required, and long-term physical adherence is required. But the cons, as I mentioned before, this 100% compliance is still unsure. If they are placed on a new type of therapy, will they be compliant? And some are not, right? We've had patients that were OSA, we put them on implanted device, and a few months later, they don't want it. It's too much, too strong. So, our doctors will try to reduce the stimulation, but then when you do that, their AHI creeps up, goes up, okay? Then surgical intervention requirement, unlike PAP. In surgical treatment, there are many options, but not all of them are paid for by the insurance. And then, of course, there's the risks, right? These devices, especially implants, they have batteries. They do have strong evidence that they are safe, but still a con, right? And then long-term studies are still not available. All right, let's go. There. All right. Now, what are future expectations with these new therapies? Self-assessment with app-based monitoring, increased patient engagement. So for the most part, our patients, just with PAP therapy, right? Do they use the app here? In the US, all the different manufacturers, you have an app. Everything is app, right? You can check after you use your device the night before, you can check how's my OSA? Do I have any residual AHI? Did I use it for longer than 4 hours? So the patient themselves can see how they use it. And when patients are engaged, they become even more compliant. Now, increased convenience, patients and clinicians alike, the payers and DMEs. Really, these technologies are meant to make things easier, right? So there are negative consequences, but things are faster. You can use this little device, you put it under your chin or you put it on your finger, and then the following day, that goes to the cloud, not in the sleep flight, goes to the cloud, that the doctors and the DMEs can see, right? And so that reduces a lot of traffic. It reduces a lot of human interaction, but also the duration of the diagnosis to the therapy, to the compliance, and to the management is all become really, really short. Then you have patient centricity with AI use. Because of so much data, everything now is personalized, very personalized, right? I'll be surprised sooner or later when you pull up your apnea app, oh, AHI is 0.3. You can also buy flowers for your wife because it's your anniversary tomorrow. Right? So everything is integrated. That's my point. Everything is now integrated because of the data that's available. But then this data is about that person, right? Not all of us require the same pressure. All of us have different requirements. All of us have different needs. And then the clinician's roles as guides and regulatory and less management. So my point here is that for us clinicians, techs, our roles are definitely changing. It's going to change. It already has started, right? We will be moving more towards the education, the compliance. We will be monitoring things, Because right now, somebody can stage, somebody can do this, somebody can do that. So what are our roles then, right? So our roles are changing. The most important thing is that we prepare for that. We prepare for that. There are more credentials coming up. There are already additional credentials for the techs, right? You have the pediatrics, you have CCSH, and soon you'll have advanced titrations. And these are all credentials. Because, why? The techs will still have work. And simply because the main group of patients that are affected with these new technologies are, when it comes to patients, are the mainly OSA patients. So those with comorbidities are still going to be in the lab. And some patients, they might present in the beginning with obstructive apnea. But once they are placed on therapy, they show something else. They might be having complex sleep apnea, or they might have insomnia with PAP. So who here has done MSLT and patient is on PAP? We've done it. It's weird, but yeah, things are going to change. All right. Any questions? Yes. Yes. So when we do titrations in our labs with these devices. So they always start with low voltage, and then they'll wait till the patient is asleep, because you have to adjust it, just like doing with PAP therapy. When you see the apnea, the events, you start to increase. But it's not just increasing one voltage at a time. You know, they have different algorithms. We have a rep here that belongs to that company, and they can explain even the more detailed titration techniques on how they do it. But yes, so you wait till patient is asleep. And so, yeah. The other one, the oral appliance, that's used during the day. I mean, the intraoral neuromuscular device that stimulates the tongue, that's used during the day. But you use it every day for over a month, and then you're supposed to see the effects. We have had patients that say they're snoring and they feel better. And so some patients will take longer than others. Thank you for your question.
Yeah.
Yes.
Yeah, hello, Ken. Thank you so much for the very informative lecture.
Thank you.
So I work for a sleep company. I'm not a doctor. And so my question is about the sleep analytics and solutions. So you've mentioned about many different analytics and solutions that is available in the US or probably in other countries outside Southeast Asia. So based on your experience and knowledge, which among the sleep analytics and solutions do you think we can bring into Southeast Asia, particularly the Philippines?
Well, yeah, I don't want to be biased, but it's
Maybe one or two each for analytics and solutions.
so without mentioning any names, I used to work for them. So that company now is not a sleep company; it's a healthcare informatics company. So when you're introducing AI and machine learning and these algorithms, you need a strong communication system. So that's one of the biggest things. Particularly in the Philippines, we have issues with connectivity. It's still very weak. We don't use the best cabling system. It's still, it could be better. But that's one of the major aspects of this. You can't depend on a weak signal, especially when it comes to having clinical judgment. So if that was to happen, you have to have the infrastructure. And here in Vietnam, I think countries that have not fully developed their infrastructure for sleep medicine have an edge. because they can start the infrastructure and create buildings and cabling and communication systems that are ready for that technology. Whereas if you have countries that are already developed and they have old system, you have to either replace or destroy the old system and put up the new infrastructure, which costs more money. And that's why it's not happening quickly, right? Even the United States, we have so many, if you think about it, that's the country that has the most advanced sleep medicine and research and technology, et cetera. But it could do more, right? The biggest hindrance is that we still have buildings, infrastructure that are not ready for this. That's why, for your question again, if I was to introduce, let's say I have Elon Musk money, I won't be going to Mars. I'll be creating I'll be laying out the necessary fiber optic, the system that improve the communication system first, and then increase the research. You need to increase research, by the way, because when you have research, you can then influence legislation, right? So research, then legislation. When you influence legislation, you will have laws that will protect the development of the medicine, right? So then you can establish more. You can also you can protect techs from leaving the country when they become our PhDs. I don't know, did I answer your question or no?
Not really.
So if somebody want company, because Philips is gone.
No, not. You don't need to mention a company. Like among the new solutions and analytics test, which of these do you think we could implement sooner or later in the Philippines? Yeah, because you mentioned about AI. So assuming that we'll be having good connections, the patient will be compliant, and the doctor will agree to it, of course. So given these three important parameters, which among the current trends or new technology or probably sleep aid devices do you think we could start using or doing?
Well, so one, if you want an ecosystem, then you go for the largest manufacturer in the world, right? ResMed, because they have the AirView, they have the small device for diagnostics, and then they have the platform for everything, for your diagnostics, for your PAP compliance, for your clinical management. You can monitor everything in their cloud-based website. It's not even it's cloud-based, so it's internet-based, so you can check it anywhere you're at. You don't need the software. That's a lot easier than to go for like the old ways. We used to use ResScan, right, or Care Orchestrator. You have to plug in the chip, right? Whereas if you have something like a cloud-based system, then you don't need all those requirements. It will be cheaper also to develop and expand in the long run, right? But the other devices, because they are separated. If you go for a smaller company, right, you can choose the other ones. You can use the one on the chin, Sunrise Medical, and there's other ones that are coming up. But they are just diagnosis. So then you need another platform for your compliance, like PAP compliance. Whereas, so that's the choice. But I think Philippines, knowing the challenges, I'd probably go with the bigger companies if they're willing to collaborate, because they can, and it's all inclusive. Yeah.
Right. Thank you so much.
Thank
Ken.
you.
Appreciate it.
Any other? Okay.
Hi, Sir Khem. Very interesting topic.
Thank you.
So regarding the, how patients can just pull up through apps, how they did, with their therapy. So this might be just an isolated case,
Mhm.
but I just want to know how to deal with, patients like this. So the issue I notice is that when they understand the meaning, what AHI, like how many times they stop breathing during their therapy. I had this patient, like, she will notice, like, oh, I stopped breathing like 34 times, even on therapy. She will, call us why this happened, stuff like that. And I check, leak is good. So how do you deal, because like it's like every week she will call. Like, I know, like, it's not, with CPAP it's not always like 100%. I'm just wondering what can I say, or how you deal with patients like this, just so they would be confident that the machine is working, their STB is being controlled by the apneas, by the machine. So
Thank you for that question. One, block.
I know, aside from
Just
not
kidding.
answering their calls, what else?
Block. No, it happens a lot. Happens a lot
Yeah.
in our lab, especially if you have a center, right? Because you can have a sleep lab or you can have a sleep center. Sleep center, you must have a clinic, a day operation, a night operation, and then a home sleep program, especially if it's accredited. But you will get those calls a lot, especially
We do everything. We don't have a setter.
yeah.
That's-
So that's well, that is a center, So if you do everything, that is a center. You're also
Okay.
doing the DME or the distributor job.
yeah.
So patients, Glenn mentioned yesterday about misperception, right? Some of these patients, you can GTS, Google that thing, right? You can Google everything. You can even change your device settings in YouTube, right? So these patients, they will be more educated than before. So there's a couple of things that we as clinicians need to do. You tabulate those calls, and you understand. And what you need to understand is what's the insight, or what are the core things they complain about, right? And so when you find the common denominator, you address that. However, I can tell you that some patients you cannot please. You cannot. I have taken patients to risk management many times. I have to do a formal complaint that it became extreme. It became harassment, right? But for those that are just not there yet, those difficult to manage patients, typically they are what? They're your mild to moderate case, right? They're your mild to moderate case, especially if they're OSA. But these patients also that are difficult, they are some of your patients that deals with complex insomnia. They are your patients that has multiple medications. These are your patients on anxiolytics or anxiety medications. So we have to have a stronger perspective and knowledge on CBTI, counseling patients on more than what we used to tell them when it comes to OSA management. Because at the end, if you just look into the insights of things, right? Why do patients complain? One, they might not feel good, right? The other is they don't think they feel good. That is not helping them at all. Okay. So you also have to know then your limitations. What helps for me, what helps is you give the patients the most realistic perspective, right? So you give them and you give them back the decision. You've been calling us. You can say it nicely, right? We've been trying to help you. You keep going back to this issue. What is that? Minimize it for them. What's the main issue they keep going back to, right? And you know how you can go to the root cause of things. There's that there's that five questions, 5 whys. You go back. Why? Why do you complain about this? And when they answer, well, because of this. Why? You go back. They will figure it out for you. because then it will become lesser and lesser reason. And that's the root cause. And then is that root cause solvable by you or not? And then, yeah, other than that, oh, this patient again, transfer to Glenn. They do that to me. They call, my staff calls, Khem, this patient. And I think he wants to talk to you now, complain. I just let them vent. Okay, I'm on the phone. They just talk. Some of them actually just want to talk. Some of these difficult patients, they just want to talk. And I'm not giving them any clear answers. I just, oh, really? Okay, so tell me more. And then after they finish talking, like they're able to express everything, they feel better just by letting it out and somebody's listening, you know? So in one's essence is that we need a lot of the development on psychological management of patients, especially for us to help the doctors. And that's why we have, you know, credentials such as CCSH, because we need to be those clinicians. We face the patients way longer than the doctors, right? In the sleep lab, minimum 8 hours. So it starts there. If the patients usually that are becoming very disrupted later in their therapy is because they didn't get many of their questions and issues answered from the beginning. I don't know if that helps now. Was that acceptable?
Yeah.
Meh.
Because I tried she has a dream station. Oh, sorry if I'm not.
No, that's fine.
I disabled like the settings that she can.
You turn it off. No wonder she's choking.
They called and asked for what happened, so I just had to put it back. But nobody, yeah, it's all good. I mean, when I did the average for a week, it was good. It was like under 5, so she's
Mm.
happy. I think she just wants to hear that her AHI is like below 5. I don't know what happened. Why it was 34 in that day, even with like good leak. And she said she slept well. I think she just wants to know like what happened.
Oh,
But
yeah.
yeah.
And I think you just pointed a good perspective there,
Yeah.
that it's therapy. When you talk about therapy, you're not talking about 1 day, 2 days, 3 days. You're
Yeah.
talking about a bigger picture,
Mhm.
right? Out of 1 week, what was your average AHI? What was your average pressure? You're not talking about tomorrow. You can have an AHI of 6, the following day 0.3, right? Why? Because you might be supine versus tomorrow you'll be on your side or upside down, right? So there's a lot of variables, but explaining to patients that how you feel is not always what's really happening with your body, right? So I explain to the patient the long-term compliance. What does it do for you, right? Dr. Castriotta's talk, if you use your PAP, you live. You don't, you die. But it's also just developing comorbidities. Thank you for your
Thank you.
question.
Any
Any
other
other
questions?
Thank you for your attention. I appreciate you. I'll check the schedule right now, and for day 2, oh no, Dr. Tuazon is next. Let me just prepare. Give me a few minutes for Dr. Tuazon's presentation. So our next talk will be on oral appliance therapy by Dr. Tuazon. Okay, without further ado, here's Dr. Tuazon.
Okay, good morning. So this will be the continuation. Okay, so just to review from yesterday. So we have an algorithm, right? So from screening to diagnosis and treatment. Today will be the treatment part of it. Okay, so just to review. So the step one of the algorithm is to screen. So anything more than 10. And you can actually customize this. If you want it 8, it's good too. So, and then step two. Step two is to ask for any comorbidities, okay, health risks. So if you have these comorbidities, highly suspect that you might be suffering from OSA, and look for risk factors. If you have some of these, you might be you might suspect that you might be suffering from that OSA. Then signs and symptoms of it. Okay, loud snoring, gasping, witness apnea, clenching and grinding, morning headaches, sleepiness. So once you have all this, suspect OSA strongly. So the next part will be, so after all this, is sleep study test. Okay, so when we to do the sleep study test, it's very important because this is where the diagnosis part is. So like I mentioned, dentists cannot prescribe yet. Okay, so we have to refer to sleep doctors, and the sleep doctors will be the one to prescribe PSG. Okay, so the next steps for today that we'll be discussing is the next 5 steps. So ENT consult is very important. And then we find out if CPAP is a good option for them, if they can tolerate it. If not, what other options can we consider? These are all what dentists can do. We can ask for a surgery, or we can do mandibular advancement device and all those things. So we'll start with this. And today we'll do this. Okay, so just to go over, so this is what we did yesterday. Anything, if your score is anything between 11 and 15, it suggests that you have a mild to moderate. 16 and over, suspect narcolepsy or severe OSA. And anything more than 10 has to be evaluated. And like I said, if you have this score, you might be okay. Right? So as for any health consequences, this is just a review. As for risk factors, signs and symptoms, if you have all this, suspect OSA. And then you do the PSG. Okay. So to be diagnosed with OSA, you'll need to undergo a sleep study, also known as polysomnography, which most of you know. So we went to this place. So this is like a sleep study test place. Okay. So I was amazed that this facility actually has, it's like a hotel room. Where is it? Can you Okay. So from what I've heard, this is the only place right now that has this facility in Vietnam. I don't know if it's Ho Chi Minh. Okay, so and this is like a hotel, right? So they have all this, they have TVs. We were there. Okay, so we just kind of check out the place. We're curious what they have and what they offer. So this is the group, and we saw everyone here, the staff. So we were all impressed by the staff, the facility, and what's most impressive is the food that they serve. Okay, so I've never seen such a big, like a giant gourami, you know? So they call it elephant ear fish or something. But what I could probably recommend is probably after all this is to have a massage. Can you play that? Like this. So that would probably be a good addition, you know? Okay. All right. So step 6 now, ENT consult. We'll start with number 6. So the goal for ENT consult is to make sure that you can breathe through the nose. So in orthodontics and in dentistry, we are big on breathing through the nose. And for us, none of the therapy will work if ultimately you're not breathing through the nose. It's very important that the mouth is closed, because when the mouth is closed, the tongue is actually positioned against the roof of the mouth. And if the mouth is open, the tongue can actually relax towards the airway. So this is we are very strong proponent of nasal breathing. So in any treatment that we do, we have to make sure that the patient can breathe through the nose. That's number 1 for us. So we always go to do some ENT consult, make sure there's no deviated septum, there's no enlarged turbinates, nasal polyps. It has to, or if you had allergies from the past, those needs to be controlled or taken. You should be taking some medications for it. Because whatever we do from there, and the patients are not ultimately breathing through the nose, whether you do CPAP, you do other treatment, Inspire, it's still not going to work ultimately, because the tongue definitely needs to be, because the tongue is the biggest obstructor. That's the biggest offense. It's the tongue. That's the one that obstructs our airway. So it's important that we have to switch our patients from mouth breathing to nasal breathing. Okay. Then next step is the patient, if the patient is recommended to wear CPAP, okay? So we have to ask, is the patient, can the patient tolerate the CPAP? Okay, so it's still the gold standard. And we are with that, you know, we don't oppose it. If you can wear CPAP, the best, okay? But some patients cannot tolerate it. Okay, so if the patient cannot tolerate that, then we should have other options for them. Like Khem said, it's still like minimum 50% compliance rate for CPAP, although it works. It's just that the thought of wearing this every night, it kind of scares the patients. Like, oh, okay, it works, but I have to wear this overnight, and then I have to worry about the fit and all those stuff. Okay, so if this works, then we're done with the step. We go now to step 10, which we reassess. Because like I said, some patients will respond very well, and then all of a sudden something happened, right? Probably patient gained weight or developed some mouth breathing again, or some nasal obstruction or allergies. Then we have to reassess again. Okay. So CPAP is still the most efficacious treatment for OSA. Okay, so there's no doubt about that. But the problem is there is really low compliance. and acceptance, which makes it not for everybody. Okay, so not a lot of treatments are for everyone anyway. So CPAP is actually one of them. Okay, so what if they're not for CPAP? Next question we ask is, what about surgery? So we ask yes or no. So when we do surgery, so now this is oral maxillofacial surgeon that we work with. Okay, so this is dental person. We collaborate with doctors, but now with the treatment, this is more like in our turf. Okay, so this is more dental. So if you say yes, probably let's consider a surgery. Then when do we do the surgery? So one of the risk factors is retrognathia, right? Poor jaw development, right? So the lower jaw. So if you have mandibular deficiency, can you play that? Oh, we go back. Let's go back. Go back, yeah. Oop. Okay, then just play that one. Okay, so this is just, you know, it's like a bilateral sagittal split. So it's like you're moving your bottom jaw forward. So this is the surgical part of it. Like I said, when you move the jaw forward, now you have more space for your tongue. Okay, so for mandibular deficiency, mandibular advancement surgery is recommended. Now, what if you have maxillary deficiency? So these are the stuff that we see also. Should we do maxillary advancement in this situation? What if it's both maxillomandibular? So maxillomandibular advancement is actually very popular. Okay, so that's mostly what is recommended. It really increases the airway size from the velopharyngeal, which is behind the soft palate, and the retroglossal area behind the tongue. So this is actually pretty good. Okay, so this is the part that when we recommend or refer. So we are on standby. Sleep dentists are on standby. So we go for CPAP. Then what about surgery? Okay, so if we satisfy, well, okay, so this patient would definitely benefit from surgery, then we go for that. Okay, but what if it doesn't need a surgery? So when do we do other treatments aside from CPAP and surgery? So this is where we come in. If it's no surgery, then we have two areas that we can help the patient. It's called expansion orthodontics or mandibular advancement device. Now we're gonna have to choose which one is gonna be better for them. So mandibular advancement device is the leading alternative to CPAP. Okay, so I wear one for myself. They are very efficient and effective for mild, but they can also be used for mild, moderate, and severe. Okay, so, and I'll show you a study that was just released this year. They did a meta-analysis. So the health impact of mandibular advancement device on OSA patients is comparable to PAP treatments. Okay, so if we have that, this is just to let you know that, hey, there's another option for this. Okay, so if some patients don't want to wear CPAP, then we have this. This is really more portable, right? You don't have to bring, but PAP machines are small now, so it's not as much of an issue as before. So, and it only requires at least 8 teeth in each arch. Okay, most patients who snore, sometimes they don't have that much teeth because of problems with gum issues, periodontal disease, because they breathe through their mouth, right? So here we just need 8 teeth for each arch. and make sure there's no advanced periodontal issues. Okay, so no issues. And test if you can move the jaw forward as far as 5 millimeters at least. You can move the jaw forward. Then that might be, because if you can't really move forward, so you can't really, you might want to consider something else. So these are the options. Okay, so this is how it looks. So basically what it does is, oh, anyway, so this is compliance sensor anyway. So now we have this. So the patient now can look at things and say, and be more proactive with their treatment, because now they can see how much they use it, and then they can correlate that to their how they feel during the day, and after they sleep, are they energized, and all those things. So basically, this is what happens, right? So there's obstructions, the air can't go in, but the moment you wear an appliance and move the jaw forward, you actually have enough space and you can breathe better. So like I said, again, this is for mild to moderate, but we can also use it in severe. Okay, so I don't know if this works. Oh, yeah, there you go. So there's not that much space right here. And then you create that space for the air to come in. Okay. So what's the specific indications for MAD? Ideal for those who struggle with CPAP. So next thing, if the patient can't wear CPAP, consider actually, okay, so probably talk to your doctor, because we can't do a mandibular advancement device until it's prescribed by the sleep doctor. Okay, then we'll do it. And it's very effective for mild to moderate. If you only have mild to moderate, this might be the best option for you. Okay. But if you have severe OSA and you cannot tolerate it, treatment option when compliance is problematic, mandibular advancement device is good for you, even if it's severe. Okay, so but we have to talk about efficacy and efficiency. Efficacy is how well a treatment works under ideal conditions. Efficiency is how effectively a treatment achieve results using at least minimum amount of resources. So for CPAP, it is highly effective in reducing AHI. Okay, is it efficient? Not as much, because the patient has to wear it every night, and compliance is the problem. If the patient is comfortable with wearing CPAP, this is the best. Okay, no doubt. With mandibular advancement device, it is effective for mild to moderate OSA, okay, by moving the jaw forward to keep the airway open. But it's most efficient, more efficient than the CPAP, because it's easy, it's comfortable, and it's easy to wear, right? There's no other appliance. You just put it in, there's no air, no nothing. It's just that. Okay, so that's why if in CPAP is highly efficient, but if patient doesn't wear it or use it, then it's really not helping them. MAD is not highly efficient, but if the patient is wearing it, then at least it's good enough. Okay, so a study in February 2024, and they did a meta-analysis this year only. They found out that they are effective also for moderate and severe OSA. Before, we're just like, you know, tethering towards severe, but it's because it's only good for mild to moderate. Now they're being bold in saying, hey, we can actually do this even with severe OSA. Okay, but again, it's perfect for mild, okay, mild OSA. And they found out that it actually also, it helps improve sleepiness, ODI, and your low oxyhemoglobin saturation. So across mild, moderate, and severe. So this is this year, okay? So that's good. That's good for us. That's good for the sleep community, that we have options now, okay? Okay, so but every time we tell the patients, hey, this is a good option for you, but there are some side effects or disadvantages. At first, you will really drool. There's so much saliva there because your brain thinks it's food. So the more you wear it, the more the brain is going to get used to it. No, it's not food. Okay, so you're not going to salivate anymore. There would be some TMJ issues, but sometimes if you have TMJ issues, it actually helps it. Okay, and there might be some changes in your bite. So the first thing that we tell the patient is your bite might change. Right away, we have to tell them that. Not everyone though, but the number one side effect of mandibular advancement device is actually your bite will change. Okay, so, but if you were to choose, you want to sleep better, feel better, or you want to look good. If you can do both, that's good because it's really not going to damage your teeth. It's just the way the bite come together. So what other options do we have aside from mandibular advancement device? Orthodontics. So orthodontics, we call it airway and sleep orthodontics. So we call it expansion. So when do we need to do this? Okay, so when you see something like this, okay, I want you to look at this. This is expansion orthodontics. It doesn't matter how old you are. Before, we can only expand until 15 years old. But now even older patients, we can actually break the maxilla and split it open. Okay, so in this case, when you see something like this, it's a crowded mouth, it's a crowded airway. Okay, so when you see a lot of malocclusion or crowding, that tells you right away that the tongue is not at the roof of the mouth. The tongue is what is your natural expander, okay? Your cheeks and your lips are your natural braces. If your tongue is up in the roof of the mouth and it's counterbalanced by your cheek and your lips, imagine you're growing when you were young and you have that, you won't need orthodontics. So why do you have this situation? Because there are now there's uneven balance. The tongue is not up there, so there's more influence of the cheek and the lips. So if there's more influence of the cheeks, nothing counteracting the opposite side, which is the tongue side, it will actually crowd, right? So whenever you see something like this, oh, okay, so the tongue was never up there. So that's one of the risk factors also. Now, if you see something like this, there's a lot in orthodontics. What do they do to relieve the crowding? They pull for teeth, right? Now, as an orthodontist, me, myself, I kind of geared away from that, especially if there are risk factors, there's signs and symptoms and comorbidities. I'm not going to pull teeth here. Because the moment I pull teeth here, what's going to happen? The tongue won't have any more space, right? So it's kind of like that. It's like you have a very tight, your tongue, you will have those indentations because it won't fit up in the roof of the mouth, right? So that's the very first sign. So if you come to an orthodontist and they do traditional treatment, and what is that? We're going to go ahead and pull some teeth and you're going to have a nice, well-aligned teeth. But actually, we are subjecting the patients to much more problem in the future. And that is why there are relapse. And if you notice, most orthodontists, they use fixed lingual retainers where they cement at the bottom because it will relapse. Because there's no balance between the tongue, which is the inside force, and the cheek and the lips, which is the outside force. There should always be that. So myofunctional therapy, I don't know if you've heard of that, is part of our therapy for patients like this. So in cases like this, what do we do? How do you fix this? Okay, can you play that one? So we Okay, so the agenda is to open it up, create more space. Remember that arch is collapsed. That the goal really is, when you do orthodontics nowadays, is to really make room for the tongue. Okay, now then after that, after we do it, we start the expansion 5 opening, right? It's like 0.2 millimeters. So it's like 5 rotations is like 1 millimeter. 1 millimeter only. And then 1 every day. So 0.2 millimeter. And it will break the mid-palatal suture. There's a suture there that you can expand. Okay. Now, this is not me. This is an oral surgeon. Okay, so for the bottom, there's no suture. Right? There's no suture. You can't really expand at the bottom. A lot of people will say, hey, we're going to expand at the bottom arches. You cannot expand. You have to split that mandible. And that's what we did. So we call it mandibular midline distraction osteogenesis. So that's the nose. So go ahead and play it. Create a cut there, right? So it's not like we're starting with that. There's already a cut just to kind of like open it up a little bit, okay? So now we're splitting here, the jaw, right? We're not expanding because there's no suture, but we still have an expander. So meaning once it splits, we start expanding it. It's open, okay? So this is before and after. So from a very, very crowded, and this is how I finished this case. This is not painful at all, except that this. But the recovery is very quick. These are all the bottom one, the MMDO is done GA. Okay. So, but the top one, you don't have to. But once we have that already in place, the reason why we're doing this, it's because now the orthodontics should really start accommodating the tongue. The tongue is your biggest obstructor. So if you don't accommodate that tongue, it will go in the airway. So what we're doing now, orthodontics should go towards that. We have to expand arches and not pull teeth, because when you pull teeth, it will just make it even shorter and narrower. So imagine if I didn't expand that and I pulled some teeth, I will be able to align it. But orthodontics should not be just aligning teeth, because like I said, you have to suspect crowded teeth is a crowded airway. So right away, you would know, hey, if there is some mild undiagnosed sleep disorder breathing here, we are actually setting them up to fail in the future. So this will be now the text. Try to see and check if they have all their premolars. A lot of their patients probably don't have those premolars and they have small, or probably they have carotid teeth. Okay, so start looking at those now and it will make sense to you. So that's why nowadays we don't pull teeth, just to align. Okay, so we will expand, accommodate all teeth, make the arch big to accommodate the tongue. And after all this, next step is reassess. Okay, next step, reassess. Reassess response within 3 to 6 or 12 months. Okay, so we are successful. The symptoms got better, AHI got reduced. You still need to reassess. In our case, we need to see the patients every 3, 6, and 12 months, just to make sure patient is compliant, symptoms are under control, and they wake up re-energized. So again, I always give this as a quote to everybody. Consider this. Ultimately, you have to breathe through your nose. And if you're not, none of what you do really matters. Somebody mentioned about leptin and ghrelin, right? So if I am doing diet and exercise, that diet's not going to work. It will work, but not really. It's almost like Ozempic. It will work, and then eventually you're going to regain it back. So when you are on a fight or flight, or you have OSA, your leptin doesn't work. That gives you like I think Dr. Trish was the one who mentioned it, that it's a satiety hormone, right? So it tells you when you're full. And ghrelin is there's Dr. Trish. She was mentioning about that leptin. And ghrelin is a hormone that tells you when you're hungry. So that's why when patients with OSA, okay, there's cannabinoid effect on that. It's almost like, how come I never get full? And how come I'm always hungry? Because those two hormones don't work. Okay, so imagine leptin. Leptin tells you you're full. If you're driving a car with your fuel gauge not working, okay, your fuel gauge is not working. So you travel from Ho Chi Minh to Halong Bay, and your fuel gauge doesn't work. So what are you gonna do? So every time you see a fuel, you will stop, right? And you're gonna fuel. Because you'll never know if you're gonna run out of fuel. Same thing when you are suffering from leptin. It affects your hormones like leptin. People will tend to eat every once in a while because the brain thinks you're not full. So it's like traveling from, like I said, Ho Chi Minh City to Halong Bay, and you're gonna have to keep eating, or you have to keep putting fuel just to make sure that you have it, right? So there's a lot of things that happen on that. So if your patient, for us, and I always tell this to everybody, my colleague, is not ultimately breathing through the nose, none of your therapy matters. Remember, all this started because we can't breathe through our nose. Do you really think if you can breathe through your nose, you're gonna have crowded airway? You're gonna have issues with breathing during sleep? If you are breathing through the nose. The only reason why you started having those issues is because now the tongue don't have any spot but the airway. If your mouth is closed, it's in the roof of your mouth. And if you're growing, if your kids are like that, if you see your kids sleeping with their mouth open, you have to close it. And if there's issue with allergies or adenoids or tonsils, go to ENT. Resolve those issues. That's the first thing. Symptoms for kids who suffer from sleep disorder breathing is ADHD. In our community, we suspect first SDB before ADHD. And the reason why kids don't have attention is, we call it attention shifting. It's because when I talk to them, right? If I talk to them and they shift their attention, it's not because they're trying to be disrespectful, but it's because if I keep listening to you, I'm gonna fall asleep. And the reason why they're hyperactive, they bounce off the wall, because if they sit in one place, they're going to fall asleep. So those symptoms, hyperactivity and inattention, is their attempt to keep themselves alert and awake. So it's a different manifestations for women, for men, and for kids. So we have to know all those. So remember that. So if you have kids diagnosed with ADHD and they're trying to give you medications, why don't you do the screening first? The screening, it's not Epworth because it's different for kids, but you still follow what are the risks, is there comorbidities, what are the signs and symptoms. If they've been diagnosed with ADHD, go through that, and if it needs a sleep study test, let's do that. Okay. So if OSA improves, monitor clinically and reevaluate in 3 to 6 and 12 months. Things change. We gain weight. Okay, so a lot of times patient will say, hey, how come last night I've been doing really well? And then my husband or my wife told me that I snore. Sometimes you just have to ask, did you drink alcohol that night? You know, sometimes there are just changes like that. Doesn't mean it doesn't work. It's just that it's more challenging now because, you know, muscles tend to relax more. Okay, so if OSA is still clinically significant, offer alternate therapy. So what I'm trying to say is, if I do orthodontics, my retainers probably would be mandibular advancement device. Okay, so now you can, or I might have to consider surgery now, right? If it's still there, right? Or we might revisit CPAP again. So it cannot be just one treatment. And that's the reason why the way I presented this is really collaboration. It's not just us dentists will treat this. We really respect this medical community. Medical community is the first for us. Hey, we suspect something here. Go ahead and do an ENT consult. Go ahead and look at your sleep doctors. Go ahead and look at your internist. How come you have type 2 diabetes? Let's try to see what's going on there. Then before you come in, I already know what's going on. Then I would know how to effectively treat the patient. This is not just, hey, a patient come in, hey, let's do a mandibular advancement device. No, it's not. That's not how we do it there. Okay. So in summary, we already know this, like the last time, I think they did this as a summary also. So there's really a lot of us that suffers from this. And it doesn't really get better. It actually gets worse, right? So it's not like, that's the reason why I want you to reassess this, because as we age, the worse we get, right? We gain weight, our muscles become more limp, right? That's why we have to exercise, right? And that's why there's myofunctional therapy, because you need to exercise your tongue also. When you gain weight, fat is right away distributed in the tongue, and the tongue actually gets fat. So that's the reason why you need to consider the tongue always. Okay. Now, if you're frequently feeling excessively sleeping during the day, you have the signs and symptoms. This is what we did, and have risk factors dealing with cardiovascular diseases. There's a chance that you might have undiagnosed or even untreated obstructive sleep apnea. Okay, so we went through all those stuff. Okay, dentists. So I know Dr. Fong is a dentist. We really play a big role in this, and somehow dentists are the captain of the team. I'm gonna claim it. The reason why, it's because we see the patients more than the medical doctors. Another reason is we look in the mouth, and most risk factors are actually head and neck, right? Nose of the bridge to the Adam's apple. That's your upper airway. So we see all those, we look into those things. So being a dentist is really important. So that's my goal in the Philippines. I've been going to the Philippines and making sure that the dentists are on board on this one, because if there's 900 million, I bet probably like 50% of their patients probably suffer from it, probably more. And if you are not seeing them, we're doing a disservice for our patients. Okay, so this is the part where I need to get a picture because they want me to show a proof that I talk about this. Okay, so if you are wanting to chase this, there are actually good programs out there, and one is in August. Dr. Stanley Liu, this is like ENTs, doctors, myofunctional therapists, and dentists. Okay, so, and then there's one in November. This is going to be in San Francisco. This one is in Melbourne. Okay, so that would be a good start. Just get to know how the community work together, right? Healthcare professionals. Now, if you want a copy of the PDF, nagmamakawa, give me a follow. I'm just starting my social media. I'm not really that active, but I might. But I will give you a copy of the PDF files for this. Okay, and thank you so much.
Are there any questions? Okay, good. We knew you're going to ask.
Yes. Again, thank you very much for your presentation. I have some question for you, and the first one, because I'm using the MID as well, but I feel some uncomfortable, like my teeth muscle pain, and not TMZ, yes, but I would like to ask you, how can we manage that problem when it's occur in our patient? And another, like, do you any tips for about the thickness of the material? Normally we need to do some exercise before we using the device. And another question related to the how long can the patient use the MID device? It mean for 1 year or less than? Yes, thank you.
That's a good question, no? So basically, when we start recommending mandibular advancement device, right? So we deprogram the muscles first. Like I said, people, some patients will have clenching and they have some bruxism. So the muscles are really very angry and active. So we deprogram them with the NTI-TSS. You can Google that according to Khem. It's a nociceptive trigeminal inhibitor, tension suppression system. So that's what it is. Once we deprogram that, this is how I do it, right? Once I deprogram it, and that means I can actually see now if the patient can actually move the jaw forward at least 5 millimeters. Okay, so then we do the George gauge. So we have to do series of calculations because minimum movement is 50%. So if you can do the most is, let's just say 10 millimeters, we start you with 5. And then from 5, we will titrate it 1 millimeter. And it will be titrated over a 6-month period. 6 months, right? And then we measure and see if it's which one is the sweet spot. Are we good in 6? Are we good in 7 or 10? Most patients, they're so impatient, so they go for 10. If you go for 10, sometimes the airway collapses, right? So you would think the more you advance, the bigger airway you're gonna get, but it's not. That's not the case. So sometimes 5 is the best, 10 is the worst. So we will find during the 6-month period which one is the best. Thickness depends if you have deep bite. So your height might be a little bit bigger, right? It will stretch. If you have a deep bite, that means your muscles are really tight. So increasing the bite actually stretches it and it relaxes it. So, but we go from 3 to 5 millimeter vertical height. That's how we increase it. That's the thickness, right? So that's the height. Is it comfortable at first? No. But it's easy to get used to it. Okay. So because especially, you know, some patients are going to say, well, it doesn't really work, but sometimes it works right away. The reason why I do the NTI TSS, because it's an appliance for them to try and see if they can put something in their mouth. It's small. So it's kind of like trainer. At the same time, it relaxes them. Once it relaxes them, then there's going to be a positive expectation on the mandibular advancement device. So now they would relate, let's say like Mr. Glenn, you know, sometimes it's the perception. So if we start with something that works and it relaxes, whatever appliance we use next, they will be just okay with it, right? So, and we have patients also the same thing. Don't want CPAP, don't want mandibular advancement device, don't want surgery. So what do we tell them? It's because it doesn't work, I don't sleep. So what do I tell them? So I tell them, how about I give you just $1 million? Will you be okay with that? And said, are you gonna give me $1 million? Oh, absolutely. Promise? I promise. Can you afford it? We'll talk about that later, but I will afford it. But then they will say, but what's the catch? You won't wake up the next day. So now once you see, you need to kind of like make them see the reason why. So that means waking up in the morning is worth $1 million. So that should be, now that you wake up, it's worth $1 million. So, and what's going to help you wake up in the morning? Alive. Your CPAP, your mandibular advancement device. That's what's going to help you. And then from then, what if you're going to do this for someone else, not for you? If you get to live the next day, who are you doing this for? Who do you want to spend that one day that you get to wake up? Who do you want to spend it with? So sometimes I stop talking about how good the appliance is. It would help you. It's almost like me saying, it doesn't matter if it helps you or not, but who's gonna appreciate that you're still around? Who are the people that still want you to be around? And once you start switching that, they start to really, okay, I guess, right? For them to just make them, you know, change their perspective is sometimes more powerful than what the appliance can do for them. But sometimes, what can the appliance do for the loved ones that still want you around? Well, it depends if they don't want you around anymore, you know? All right. But to then do it for your haters, right? Just to be around for your haters. Okay. Anything else?
Okay, Dr. Ellie. Okay.
Hi, I just want to ask you if you have any experience of patients using both the CPAP and MAD at the same time.
Yes, actually, a good question. It's called hybrid,
Hybrid.
right? That's a very good question. You know, one of the issues with CPAP intolerance is you know how those dogs in the commercial outside the window of the car, and then they got that air flowing through that. It's too much power. It's because there's so much, you need so much pressure to make sure that it opens up your airway. But what if you wear something and it's already opens it up a little bit? Then you don't have to put a lot of pressure anymore. Then you can tolerate that more. So sometimes we do that. Actually, we don't really, well, I've been wearing a CPAP, but you know, sometimes I wear it, sometimes I don't. But what makes you not wear it all night? It's because it's too much pressure, because probably that's how much pressure you need. What if I tell you we can minimize the pressure? Would you be interested? I would ask them. I'm the person who's not, oh, let's do this, let's do this. You have to ask questions all the time. What if I tell you I can make it better? Would you be interested? And then you go like this. Would you be interested? And they will nod their head no matter what. They will, okay. Then let's try and do a mandibular advancement device, because that opens up your airway, and then you can talk to your doctor. They could probably start minimizing it through sleep study tests and see how that works for you. It really works. That's the magic of it. The problem right now that we're having is although we have collaborations with doctors, but with treatments, it's still, I do this my own and they do it their own. But we sleep dentists, we really want to combine. Hey, if this works for you, let's do the mandibular advancement device. Opens up a little bit of your airway by moving your jaw forward. There's not that much pressure you need. Win-win for the patient. So that would be that's a good question.
Yeah, I just want to share with you that I have a patient using CPAP initially, and he has a very high central events. So I recommended MAD with CPAP, and the central events really goes down.
That's good. Yes, there you go. So try it. Why not? Right? There's no harm. If you can actually, if the problem is the pressure, that would be the best, right? But there's so much stuff. Now, okay, so we always do this. If you're gonna wear the mandibular advancement device, go for the nasal one, the CPAP. Because like I said, if you can do the nasal, it's the best. Like I said, if you can do we're okay with this, because whatever works that help you. But if we can switch you from the, what do you call this? The
Full face.
the full face to the nasal, and then you wear the thing, that's a perfect combination right there, right? Your tongue is closed. When your jaws move forward, your tongue is out of the airway, and you're closed, and then you're breathing here. That carries over throughout the day, because now, if you're a mouth breather through the night, during the day, and you're nasal breathing at night, you might carry it over during the day. Mouth breathing is not a good thing. It gives business to dentists. Good thing for us. Yeah.
Any other questions? Okay, we're going to take about a 30-minute break, and then we'll continue with Dr. Estrella next. So go ahead and take about a 30-minute break.